Hello, I'm Dr. Len Lilly, and welcome to the cardiovascular section of this course. I hope you're doing well and staying safe in this unusual time. Over the past year, there have been a number of important advances in cardiovascular medicine, many of which we will present in today's live and pre-recorded sessions. In this first overview lecture, I'd like to highlight a few key advancements that affect the practice of cardiology and are topics that also have a high likelihood of appearing in board exam questions. And so we'll do this in a question and answer format, and we'll start with a topic that has dominated the past half year, which is COVID-19. Now, I'm going to present a case and then ask a question. So this is a 52-year-old man who presents to the emergency department with fever, 100.5 degrees Fahrenheit, a non-productive cough, and fatigue for the past several days. His past medical history is notable for hypertension treated with lisinopril. On examination, his blood pressure is 110/72, heart rate 96, and his oxygen saturation is 93%. His chest X-ray shows bibasilar ground glass opacities, and PCR testing is positive for SARS-CoV-2. He's admitted to our special pathogens unit, and on the second hospital day, he describes increased dyspnea without chest discomfort. The electrocardiogram shows 1.5 millimeters of ST elevations in the inferior and lateral leads. His high sensitivity cardiac troponin T returns elevated at 18 nanograms per liter. He remains hemodynamically stable with normal blood pressure. So the first question is, which would be the most appropriate course of action at this point? Would it be A, to send him to the cath lab for emergency coronary angiography, B, order intravenous fibrinolytic therapy within 30 minutes and then transfer it to the coronary care unit, C, prescribe hydroxychloroquine and azithromycin and discontinue lisinopril, or D, obtain an urgent echocardiogram? And the answer that we're looking for here is, in this hemodynamically stable patient, to consider obtaining an urgent echocardiogram rather than rushing directly to the cardiac cath lab and potentially exposing people to active SARS-CoV-2 unnecessarily. Now, there are many facts that we've learned about cardiovascular effects of COVID-19 in the last several months. The first is that there's a wide range of cardiac involvement. About 7 to 28% of hospitalized patients with COVID-19 have evidence of myocardial injury as determined by rising cardiac troponin or abnormal electrocardiographic findings. In patients in the ICU, the percentage is even higher. There is a high percentage of hospitalized COVID patients who have underlying cardiac disease prior to their myocardial injury, most specifically hypertension, 64%, underlying coronary artery disease, 33%, and underlying cardiomyopathy, 15%. It's important to recognize that myocardial injury may not manifest until 1 to 2 weeks after symptom onset, after the respiratory symptoms have become stable. And myocardial injury is associated with increased mortality in COVID-19 for sure, but not all myocardial injury represents an acute coronary syndrome. So what we've learned is that there are at least 5 different mechanisms of cardiac injury in patients with COVID-19 with ST segment changes. And they include the acute coronary syndrome that's typical of a type 1 MI due to plaque disruption that can occur in anyone. More commonly is demand ischemia in COVID-19 due to oxygen supply-demand mismatch related to hypoxemia, tachycardia, hypotension, a type 2 MI. Third, patients with COVID-19 can develop myocarditis, either because of viral invasion or on the basis of cytokine storm-mediated processes. Fourthly, microvascular dysfunction can contribute to myocardial injury through the development of vasculitis or a prothrombotic state with microthrombi formation. And finally, as with any patients who are severely ill, there can be the development of a stress-type Takotsubo cardiomyopathy. Now, Dr. Bahula is going to present an entire lecture on COVID-19 and appropriate algorithms as part of the pre-recorded lectures in this course. But suffice it to say for now that if you have a patient who has ST elevation in the presence of known or suspected COVID-19, The first step is to assess symptoms and hemodynamic stability. And then, if possible, if the patient's hemodynamically stable, to try not to rush right to the cath lab, if possible, but to obtain an ultrasound, either a point of care ultrasound or a standard transthoracic echocardiogram focused on looking for wall motion abnormalities, and using that to decide how to proceed. For those individuals who have a higher suspicion for STEMI, that is to say typical chest discomfort symptoms, territorial changes on the electrocardiogram with ST elevation and the specific distributions of anatomic myocardial infarction with reciprocal changes in opposite leads, and specifically wall motion abnormalities and a territorial distribution worrisome for an acute STEMI, those patients with high suspicion should proceed to urgent coronary angiography, and if a culprit coronary lesion is identified, to proceed with primary percutaneous coronary intervention. On the other hand, for those patients who have a lower suspicion for STEMI, that is to say they may not have typical symptoms, in this patient's case, he had shortness of breath but no chest discomfort, for example, the presence of diffuse ST elevations in a non-territorial distribution without reciprocal changes, and non-territorial wall motion abnormalities on echocardiogram, there is less concern for STEMI, and in those individuals, a more elective approach can be taken to performing coronary CT angiography, and if proximal coronary disease is identified that's concerning for an acute coronary event, then the patient can proceed to the cath lab and still undergo angiography and primary PCI. But on the other hand, if that is not found, then a more elective workup, other non-invasive testing, such as cardiac MR to look for myocarditis, PET scans, for example, may be more appropriate and would prevent the exposure of personnel to COVID-19. Now, one of the parts of the questions here was whether or not the renin-angiotensin inhibitor should be discontinued, whether lisinopril should be discontinued. So there have been early theoretical concerns about the fact that the viral spike protein of SARS-CoV-2 binds to the ACE2 receptor, which is upregulated in patients who take ACE inhibitors and ARBs, but there is no evidence to date that renin-angiotensin system inhibitors increase susceptibility to COVID-19 or worsen disease outcome. Now, although COVID-19 has dominated what we've been doing over the past several months, there have been many other studies over the past year that are critically important to the daily practice of cardiology. One of the most important studies released this year is known as the ischemia trial of patients with stable coronary artery disease, in terms of whether initial invasive or conservative strategies are appropriate for patients with stable CAD with positive exercise tests. And so for this question, we'll start with a 68-year-old woman with hypertension, a history of elevated LDL cholesterol, a former smoker, who presents with 6 months of exertional chest discomfort climbing stairs or walking up inclines, occurring once or twice weekly without any progression. She's been treated with aspirin, statin, beta blocker, and ACE inhibitor therapies, and her recent lipid profile showed that her LDL is 72 milligrams per deciliter, HDL 60, and triglycerides 120. She undergoes exercise treadmill testing. At baseline, the heart rate was 72, blood pressure 130/78. She stops at 5 minutes 50 seconds because of chest discomfort, typical of what she's been experiencing, having achieved 85% of the maximal predicted heart rate. Her blood pressure rises appropriately with exercise, and the electrocardiogram shows 2 millimeters of ST depressions in leads 2, 3, AVF, and V4 through V6, consistent with ischemia that resolve 1 minute into recovery. So the question in this woman, who has typical symptoms of coronary disease in a stable pattern, but a very positive exercise test, based on her history and stress test, which of the following would be an appropriate course of action? Would it be A, refer for coronary angiography directly, B, repeat the stress test with scintigraphy to quantify the degree of ischemia? Is it C, to intensify her anti-anginal and lipid-lowering drug therapies and consider a coronary CT angiogram? Or D, no changes in her medications is indicated, no further testing is required? Well, the answer that we think would be best here would be, in fact, C, to intensify her anti-anginal and anti-lipid-lowering therapies and to consider coronary CTA. And this is based on the ischemia trial, which was published this year. It involved 5,179 patients, a mean age of 64, who had stable coronary disease and moderate to ischemia on exercise testing, as this woman demonstrated. They excluded patients who had recent acute coronary syndromes or severe left ventricular dysfunction with an EF of less than 35%. Most of the patients underwent CT angiography to exclude left main disease and non-obstructive CAD. The patients were randomized to optimal medical therapy or optimal medical therapy plus an invasive strategy, which included angiography followed by percutaneous coronary intervention or CABG as indicated. The primary endpoint was to assess for cardiovascular death, non-fatal MI, hospitalization for unstable angina, heart failure, or cardiac arrest. And the secondary endpoints included angina-related quality of life assessed by a detailed questionnaire. The patients were followed for a median of 3.2 years. It's important to note that in the invasive strategy group, nearly all of the patients did in fact undergo angiography, and the vast majority underwent revascularization. 3/4 underwent percutaneous coronary intervention, 26% underwent CABG. In the conservative strategy group, a large percentage also ultimately underwent angiography, 26%, because of the development ultimately of an ischemic event or inadequate symptom control, and 21% of those underwent revascularization. The medical therapy was in fact optimal. The LDL achieved on average in this study was 64 milligrams per deciliter below the target of 70. And the systolic blood pressure at the end of the trial was 129 millimeters of mercury at the desired target range. The results of the study are shown here. The primary composite outcome showing the cumulative incidence of cardiovascular death, non-fatal MI, hospitalization for unstable angina, heart failure, or cardiac arrest versus years of follow-up on the x-axis. And you can see that the invasive patients are shown in red and the conservative patients are shown in blue. And there was no significant difference between the two strategies. The HR is shown here. And what you can see is that early on in the first 1 year or so, first 6 months to 12 months of therapy, there was actually an increased incidence of these complicating factors, these primary outcomes among the invasive group, primarily related to complications of the procedure itself. And then after about 2 years, there's a crossover, whereas the patients in the conservative strategy had more events. But in total, there was no difference between these two strategies. The one thing that was different is that in the invasive group, there was improved control of angina and better quality of life scores on the questionnaires than in the conservative group. So the takeaway message from the ischemia trial is that for patients with chronic stable angina and moderate to severe ischemia on exercise testing, catheterization and revascularization do not reduce rates of cardiac events beyond optimal medical therapy. An invasive strategy does lead to better control of angina. So this study supports the use of coronary CTA to exclude left main disease and to consider optimal medical therapy without invasion in those patients who are otherwise stable. On the topic of cardiovascular risk reduction, the third question is, a 62-year-old woman with hypertension presents 1 year following a non-ST segment elevation MI. Her fasting lipid profile on atorvastatin 80 milligrams daily shows an LDL of 50, an HDL of 40, and triglyceride levels of 180. The question is, when added to statin therapy in a patient like this, which of the following has been shown to reduce the risk of future cardiovascular events? Is it A, niacin, B, fenofibrate, C, bempedoic acid, or D, icosapent ethyl? And the correct answer here is D, icosapent ethyl. Why is that? This is based on the REDUCE-IT trial, which was published over the past year, assessing the effects of icosapent ethyl in patients such as this for hypertriglyceridemia. This is a study of 8,179 patients with a mean age of 64 who had either established cardiovascular disease or diabetes plus at least one other cardiovascular risk factor, in patients who were already on a statin, who had already achieved an LDL of less than 100 milligrams per deciliter, but whose fasting triglyceride levels were still elevated, greater than 135. The patients were randomized to either placebo or the addition of icosapent ethyl, which is a highly purified form of icosapentaoic acid, 2 grams twice daily. And the primary endpoint was cardiovascular death, myocardial infarction, stroke, coronary revascularization, or unstable angina over a median follow-up of 4.9 years. The primary endpoint is shown here on this slide. The placebo-treated patients are shown in red. Those patients who were randomized to icosapent ethyl are shown in blue, and there was a very significant difference. There was a 25% reduction in the primary endpoint among the patients who took the icosapent ethyl. The adverse effects in this study were small. There were more patients on icosapent ethyl who were hospitalized for atrial fibrillation for unclear reasons, but that was about it. And therefore, because of this positive outcome, this benefit in patients who have residual hypertriglyceridemia after control of LDL cholesterol, the FDA approved the expanded use of icosapent ethyl as an addition to maximally tolerated statin to reduce cardiovascular events when triglyceride levels are at least greater than 150 milligrams per deciliter in patients who have established cardiovascular disease or diabetes with other risk factors. Now, one of the other choices in this question was bempedoic acid, and just some points about this newly approved agent. This is a lipid-lowering drug that acts in the same pathway that statins do, but 2 steps higher upstream of HMG-CoA reductase, where statins act. It inhibits ATP citrate lyase in the cholesterol synthesis pathway. As a result of reduced LDL production, the liver upregulates hepatic receptors for LDL, which enhances LDL clearance from the circulation and reduces circulating LDL levels. Bempedoic acid is a once daily oral medication, and it results in about a 19% reduction in LDL cholesterol when added to statin alone, which is about the ballpark of what ezetimibe does. But when bempedoic and ezetimibe together are added to a statin, that results in an additional 30% reduction in LDL cholesterol. So these are significant numbers. Now, there have been no randomized trials to look at clinical outcomes with bempedoic acid. All we know is that it can significantly lower LDL cholesterol. So it's indicated at present for additional LDL lowering added to a maximally tolerated statin in patients who have coronary disease or heterozygous familial hypercholesterolemia. What's also important to note is that the enzymes responsible for activating bempedoic acid do not exist in skeletal muscle, so myalgia is theoretically avoided. However, nothing is free, and there have been case reports of rare tendon ruptures among elderly patients on this drug, and also seemingly a slightly increased incidence of gout. Another caution is that when combined with simvastatin at doses of greater than 20 milligrams a day, or pravastatin at doses greater than 40 milligrams a day, there is an increase in the serum statin level, which theoretically could increase the statin toxicity. Let's move on now to heart failure, which will be covered in greater detail in one of your live lectures today. Consider for this question a 58-year-old man with a history of hypertension who has non-ischemic heart failure with reduced ejection fraction, an EF of 36%. He's currently treated with sacubitril valsartan, metoprolol succinate, spironolactone, and furosemide. Yet he continues to manifest New York Heart Association class 2 symptoms of heart failure. He has no history of diabetes, no history of smoking, or dyslipidemia. On exam, his blood pressure is 122/66, his heart rate 62, his oxygen saturation is 96%. His jugular venous pressure is 7, his chest is clear. Cardiac exam shows no gallop or murmur. There is trace edema at his ankles, and his estimated GFR is 62. Question for this man is, which of the following statements is correct? In this patient with heart failure and persistent symptoms, with the addition of the SGLT2 inhibitor dapagliflozin reduce his risk of cardiovascular death and worsening heart failure? Or B, dapagliflozin is not an appropriate therapy for this patient as he is not diabetic? Is it C, dapagliflozin in such a patient increases the risk of peripheral arterial insufficiency and limb amputation? Or D, dapagliflozin should not be combined with inhibitors of the renin-angiotensin system in heart failure patients? So if you think about that, the answer that we're looking for here is A, the addition of the SGLT2 inhibitor, dapagliflozin, would reduce his risk for cardiovascular death and worsening heart failure. And we know this based on studies that I will show you now, but the predicate for this, where this even trial came from, is that we knew that from diabetes studies over the past several years that have included SGLT2 inhibitors, that the incidence of heart failure hospitalization or cardiovascular death was reduced. So here are 4 studies looking at SGLT2 inhibitors, the DECLARE TIMI 58, CANVAS, EMPA-REG outcome, and CREDENCE. And these are listed on this graph. The studies that involve patients who had greater cardiovascular disease at baseline are geared towards the right. And the light bars in each of these comparisons are the placebo-treated patients, and the darker orange bars are those who received the SGLT2 inhibitor. And in every case, there was a significant reduction in heart failure hospitalizations or cardiovascular death among these diabetic patients. Now, very few of these patients had heart failure at baseline, so this was more or less a prevention trial, suggesting that these drugs did something to prevent heart failure development and cardiovascular death among the patients. And so this study, known as the DAPA heart failure trial, randomized patients to dapagliflozin in patients who had heart failure with reduced ejection fraction to see if there'd be clinical outcome benefit. And so this included 4,744 patients, all of whom had symptomatic heart failure, class 2 to 4. 68% of the patients had class 2 heart failure, but fewer than half of the patients were actually diabetic. The patients were randomized to dapagliflozin 10 milligrams daily or placebo and followed for a median of 18.2 months. The primary outcome was cardiovascular death or heart failure exacerbation requiring admission or requiring outpatient intravenous diuresis. Now, the patients were well treated at baseline. This is the dapagliflozin group and the placebo-treated group. Over 90% of the patients were on an ACE inhibitor, an ARB, or sacubitril valsartan. And over 95% of the patients were on a beta blocker. Nearly 3/4 of the patients were taking a mineralocorticoid receptor antagonist. All very well treated. The basic results from this study showed, looking at the primary outcome of cardiovascular death or heart failure exacerbation requiring admission or outpatient intravenous diuresis, the patients who received DAPA are shown in blue, the patients who received placebo are shown in red, and there was a 26% reduction in the primary outcome among the patients randomized to the SGLT2 antagonist. Now again, these are patients who primarily are not diabetic. When looking at heart failure exacerbations alone, there was also a significant 30% reduction in hospitalizations among patients who got the drug. Very impressive results. Now, when subgroup analysis looked at patients who did or did not have diabetes, it didn't make any difference. Looking at those who did or did not have diabetes, the dapagliflozin resulted in better primary outcomes. And as far as safety is concerned, discontinuation was the same in both groups. There's no difference. And looking at some of the more concerning potential side effects of these drugs, volume depletion, renal adverse effects, amputation, which had been suggested with a SGLT2 inhibitor in an earlier study, none of these occurred with any increased frequency compared to placebo. So in May, just a couple of months ago, the FDA approved dapagliflozin for class 2 to 4 heart failure with reduced ejection fraction patients for the purpose of reducing the risk of death and heart failure exacerbation. All right, well, I think that that's enough information for this first overview session of the cardiovascular part of this course. Some of these topics will be expanded on in today's other live and pre-recorded lectures, and there'll be many other advances of importance that will be presented. So thank you for your attention. Good luck, and please stay well.